Good morning and Assalamu alaikum everyone. Kindly please settle down as we are going to start with the recitation of the Holy Quran.
Bismillahir Rahmanir Rahim. Wal 'asr. Innal insana lafi khusr. إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر.
Good morning, ladies and gentlemen, and welcome to the second day of PSR 2025. My name is Haris bin Khalid.
And my name is Kainat Amir.
And we are fourth year MBBS students from Center Park Medical College. Before we begin, we would like to announce a few rules of the session. Kindly put your mobile phones on silent mode, maintain decorum, and refrain from unnecessary movements. A Q&A session will follow the talks. However, due to time constraints, we will not be taking questions directly at the microphone. Instead, attendees are requested to obtain Q&A cards from the ushers, write concise and relevant questions, and pass them on to the chairs via the ushers. We thank you for your cooperation. Yesterday, we had a truly enriching day, featuring comprehensive sessions on adult and pediatric rheumatology, hands-on MSK ultrasound workshops, and our landmark short pediatrics course under APLAR patronage. We hope you found the lectures, practical demonstrations, and interactive discussions both informative and inspiring. Today promises to continue the momentum with a series of keynote lectures from distinguished experts, sharing the latest advances and practical insights in rheumatology.
For our first session today, we are honored to invite Professor Nagat Mir Ahmed, Patron-in-Chief PSR, Chair, Arthritis Care Foundation and Chair Fellowship Program, CPMC and National Hospital, Dr. Syed Mahfouz Alam, Consultant Rheumatologist from Karachi, and Professor Samia Malik, a renowned gynecologist from National Hospital and Medical Care Center, Postgraduate Institute, Lahore, to chair this session along with Dr. Bilal Azim Butt, General Secretary, PSR, and practicing rheumatologist from FJMU as co-chair. May I request our esteemed chair to kindly join us on stage.
Without further delay, let's welcome our first keynote speaker, Dr. Aisha Lateef, who is a consultant rheumatologist at the University Medical Cluster, National University Hospital, Singapore. Dr. Lateef is a distinguished clinician with extensive experience in systematic autoimmune diseases, with a particular focus on managing complex cases in women of childbearing age. Today, she will be presenting on pregnancy in lupus, navigating risks, and optimizing outcomes. Please join me in warmly welcoming Dr. Aisha Lateef to the stage.
Assalamu alaikum and good morning. It's always a pleasure to be invited back home. Okay, seems like pregnancy is becoming an area of talks that I always cover. So I was asked to cover pregnancy in lupus, navigating risks and optimizing outcomes. And why is it such an issue? Pregnancy in lupus is getting increasingly common. These are women of childbearing age. Most lupus patients are young women, and they have comparable fertility to their normal counterparts, except like when you have used cyclophosphamide and stuff like that. So it is common, but then it poses a very unique challenge because lupus itself is an immune dysregulation. That's why you have an autoimmune disease. On the other hand, pregnancy is a state of immune adaptation to tolerate an allograft. Fetus is half maternal and half foreign, and yet it is tolerated most of the times. So there is immune adaptation, there's immune dysregulation, and when they interact, unique challenges happen. And it becomes a very high-risk situation where you need to now not only control the disease, but as well as take care of the safety of mother and the child. And you need very close multidisciplinary care, and I'm really glad to see that our gynae and ops colleagues are here today. And so what are the issues? What happened? Pregnancy affects lupus. So there is higher risk of flares. Percentages vary according to which study you are picking up. Most of the flares are mild, problem becomes that a lot of physiological changes of pregnancy overlap with lupus disease activity, and recognition may become a problem. So just follow them closely, try and use clinical judgment as well as certain investigations to differentiate. There are certain predictors, so if the disease is active at conception, or there's past history of nephritis, or people discontinue hydroxychloroquine, which happens a lot of times, the risk of flare becomes higher. Other than flares, the pregnancies in lupus put the mother at risk. Hypertension, gestational DM, infections, operative deliveries. There are higher incidences of all these complications. The one feared most is preeclampsia. So a large percentage of lupus pregnancies are affected by preeclampsia, which occurs earlier as well. Preeclampsia itself has predictors, which of course my ops colleagues will know better than me, but obesity, hypertension, family history. And then there are lupus-associated factors like lupus nephritis, presence of APLs, thrombocytopenia. And in addition to preeclampsia and all these adrenal complications, we also have suboptimal obstetric outcomes. Pregnancy loss gets most of the attention. It is decreasing with the better management nowadays. More and more pregnancies come to a successful outcome, but still the risk of preterm birth and growth restriction with IUGR and small for gestational age babies is high. Again, same predictors, APLs, thrombocytopenia, nephritis, low complement level, which is a surrogate marker of disease activity. And for preterm birth, thyroid disease has been shown to be associated with a worse outcome. So at least in Hopkins cohort, everyone gets a screen for thyroid disease and treated with thyroxine even if there's subclinical hypothyroidism. The best way of optimizing a pregnancy in lupus is to plan it. Better, easier said than done. A lot of time we are faced with patients who come in and just declare to you that they are pregnant and just deal with it. But if it is an ideal situation, then the best way is to actually plan it, talk to the patient, look at the disease activity at the preconception visit. Is the disease in remission? If the disease is in remission, then we talk about further measurements and other factors and other steps to optimize. But if the disease is not well controlled at that point, contraception becomes an important part of optimizing these outcomes, because contraception in lupus is, or any rheumatic disease, is very important, but it is often overlooked. Studies have shown that less than half of the women get any counseling, and there is inappropriate use of contraception in such settings. Patients expect this. They may not initiate this discussion, especially in the local context, but it is important, at least in my practice, if I'm prescribing a drug that is teratogenic or stuff, we do broach the topic of contraception with every woman. And what are the options? There are options available. Barrier methods are most commonly used, but they have a very high failure rate, so do let your patients know. Oral contraceptives gets a very bad press, but they are safe. They are safe in stable lupus, and large randomized controlled trials have shown that. However, the lupus which is active or which has APL positivity, that's where OCPs should be avoided. The other common and easily available alternative is progesterone-only contraceptive, either in the depot form or oral or implantable. There is some literature to show that it actually helps with the disease activity, but there is poor gynecologic tolerance. There's concerns about bone health. So anyone who receives a depot progesterone, their BMD goes down, but it reverts back to normal when it's discontinued, except in lupus patient, where it never recovers back to baseline. So limit the use, but it is an option. And intrauterine devices are definitely safe. There were concerns about infection, but again, the Selena studies have shown that there is no increased incidence of infection with the use of IUDs in women with lupus or any rheumatic disease. Just be cautious about the thromboembolic risk. Oral contraceptives, the combination pills, increase the risk of vascular events, venous thromboembolism, as well as MIs, strokes. And this risk is influenced by other thrombophilic factors. And APLs are the thrombophilic factors. They can become a second hit in a woman who is given OCP. So all lupus patients should be screened for APLs before they are prescribed for OCPs. So to sum it up, ACR does suggest that in a lupus patient, when you are discussing contraception, the important thing to know is their APL status. If they are APL positive, then your options are limited, IUDs or progesterone only. If you see, a barrier contraception doesn't even come here. The most commonly used one does not make it here because it is considered very low efficacy, higher risk of unplanned pregnancies. So if APL positive, IUD or progesterone only. If it's negative and the disease activity is low, almost anything can be used except estrogen patch. Estrogen patch delivers higher estrogen content and has shown to increase the risk of disease flares. So usually we advise to avoid estrogen patch in women with lupus, but everything else, if your disease is low activity or stable, can be used. If it's high to moderate disease activity, then OCPs are contraindicated because there's no literature of its safety in that particular situation. Okay, so we have talked about contraception. Your patient is now coming to you. Good disease control. What's next? Evaluate for any high-risk situations. There are certain situations in which we will advise against pregnancy. Limited situations, but they are like severe flare within the last 6 months because then your disease is unstable, severe lupus nephritis, stroke, severe preeclampsia or HELP despite therapy because history of adverse pregnancy outcomes predict the outcomes in the next pregnancy. So if a woman's life has been at risk once, we generally advise against it. Or severe end organ damage. So pulmonary hypertension, restrictive lung disease, renal failure, heart failure. When the end organ damage is high or very severe, is the maternal life that is at risk. So pregnancy is contraindicated in these conditions. I would advise against it. If none of them is present, your patient is in good disease control, stable lupus, let's move forward. And that's when we start talking about what are the medications that the patient is on and do we need to optimize them. And then we risk stratify the pregnancy according to presence or absence of certain autoantibodies and disease activity, which will then have implications on the management during the pregnancy. So medications use. A lot of women just discontinue everything out of fear. It will affect my baby. And that's the worst thing they can do because uncontrolled disease is worse than a controlled disease with medication. Let's go through the medicines one by one. Non-steroidal anti-inflammatory generally considered safe in first and second trimester, although there is emerging literature to show that first and second trimester use might be associated with some congenital malformations. The recommendation is use with caution in first and second trimester, but definitely discontinue during the third trimester because of the risk of patent ductus arteriosus. Corticosteroids, safe for the baby. So most of the non-fluorinated corticosteroids like your prednisolone gets inactivated by placental hydroxylases. So they don't reach baby in any high concentrations. It's the maternal risk of DM, risk of hypertension, premature delivery. That's why we advise to use the steroids as little as possible, as short as possible. What about the fluorinated corticosteroids? They can be used in certain indications like betamethasone, dexamethasone, especially in patients who have developed neonatal lupus syndrome, or if it's a premature delivery and you need it for the lung maturation of the fetus. But try and limit the use to one course. There's some literature of impaired neuropsychological development of the child with use of higher doses of steroid. But it's not been replicated. Just have to use with caution as little as possible. Hydroxychloroquine, I'll touch on it again a little, but this is one drug that was strongly recommended to be used, continued, and even started if patient is not on hydroxychloroquine. Multiple beneficial effects, reduces the risk of disease flares, neonatal lupus, or even in benefits in APL pregnancies. What immunosuppressants can be used? Azathioprine, calcineurin inhibitors, documented efficacy and safety, previously in transplant literature, more and more emerging in rheumatology literature. One small study showing that azathioprine can affect the development, the neuropsychological development in offspring, but it's not been replicated. Limit the use of AZA to 2 milligram per kg per day because of the risk of fetal cytopenias. Explain the possibility, but don't scare the patient. I mean, it's just one study. When it comes to antihypertensives, unfortunately, limited options. Old drugs like methyl-dopa, labetalol, nifedipine, hydralazine. Some impairment of uteroplacental flow with the use of labetalol and hydralazine. But again, these are the only options available if the mother needs them. Okay, aspirin. So aspirin is well known to reduce the risk of preeclampsia in any pregnancy. And lupus pregnancy are at a higher risk of preeclampsia. So it is now generally recommended to start aspirin in all lupus pregnancies. 12 weeks if APL is negative, because then you are just using it for preeclampsia prevention. At conception if you are APL positive, because then the use is more for pregnancy stabilization, reducing the risk of pregnancy loss as well as preeclampsia prevention. So aspirin for all lupus pregnancies regardless of their APL status. TNF inhibitors, of course not in lupus, but for the completion's sake I've included them here. They're safe. Previously we used to say discontinue in 3rd trimester because of the placental transfer. The current consensus is you can continue it throughout the pregnancy. Only thing is to defer live vaccinations in the baby if TNF inhibitors are continued throughout the pregnancy. If you do not want to defer the live vaccination in the baby and mother's disease allow discontinuation, then discontinue according to the half-life of the different TNF inhibitors. But if mother has a severely active arthritis, not in lupus setting, then please continue. And you can just defer the live vaccination for 6 months. Other biologics, we don't have enough literature to show, recommend either for or against. So general advice is avoid them. Things that can use is sulfasalazine, colchicine, IUIG. Again, not so much in lupus setting. What should not be used? Of course, things like which are teratogenic, abortifacient, like methotrexate, leflunomide, mycophenolate, cyclophosphamide. One study of use of cyclophosphamide in 3rd trimester after organogenesis. Outcomes are not that great, so probably reserve it for very life-threatening disease. If mother is going to die, the baby will die anyway. So if you can even save mother by the use of cyclophosphamide, then by all means. And of course, thalidomide. The small molecules, there isn't enough literature for any recommendation. Hydroxychloroquine, the drug that should be used. Continued use leads to reduction in disease activity, improve maternal and fetal outcomes. It is safe. No increase in congenital malformations. And it reduces the risk of congenital heart block, beneficial in APL pregnancy. So 2 drugs that are very important for lupus pregnancies are hydroxychloroquine and aspirin. If you can just remember that. And our patients need to know, because there's a lot of fear. There's this conception that drugs are bad. And it's not just us. Internationally, you can see a lot of patients discontinue. They don't fill in their prescriptions. They don't fill in methotrexate, mycophenolate, that's fine. We don't want them to take it. But they also stop their hydroxychloroquine, which is actually beneficial. So we need to educate our patients about the safety, because pregnancy is a very emotional state for a mother. She would do anything for the baby, even including stopping her medicines and letting her disease flare. So please educate them. What about lactation? Limited evidence. Nobody takes bloods from the babies to find out whether the drugs is there or not. We go by pharmacologic properties of the drugs. So small molecules, lipophilic molecules get diffused in more, while larger drugs or protein-bound drugs don't cross extensively into breast milk. As a rule of thumb, follow the pregnancy guidelines. The secretion in breast milk is related to the peak plasma concentration of the drug. So just have a time interval between the drug injection and breastfeeding if you're worried. Like if the prednisolone dose is more than 20, advise the mother, don't breastfeed for 2 hours or express and discard and then continue breastfeeding. What about fathers? They can take everything. So previously we used to say methotrexate affects and don't take it, but current evidence suggests that fathers can continue anything while attempting conception except cyclophosphamide, which should be discontinued at least 3 months prior to any attempts at conception, and thalidomide. We do not have enough literature to give any recommendations about the biologics or small molecules. But generally, methotrexate, leflunomide, mycophenolate, rituximab are all fine for the fathers. Okay, so now we have adjusted the medications. What about the antibodies and specific situations? Sorry, I don't know what happened. Okay, so APLs, not just prothrombotic, they have multiple mechanisms. They lead to inflammation. There's direct effects on trophoblast as well as on the vessels. So vasculopathy, inflammation, thrombosis all contribute to pregnancy complications. And this is reflected in the new ACR-ULAR classification criteria, where it's not just thrombosis, but a lot of microvascular phenomena as well as hematologic and cardiac that comes into it. The pregnancy criteria remains pretty much the same, although there has been a lot of additional features and weightages, points assigned. In a nutshell, 3 or more pregnancy losses, early losses, 1 late loss, severe preeclampsia or early birth. That's when we say that it is obstetric APS. Main issues: preeclampsia, placental insufficiency, IUGR, and preterm death. Management strategies depend on the risk profile. Asymptomatic carrier, only obstetric complications or thrombosis. If it's only APL positivity, consensus is low dose aspirin, although evidence is rather not so strong. Obstetric APS is where large studies and meta-analysis has shown that combination of prophylactic doses of heparin and low dose aspirin reduces the risk of pregnancy loss by 54%. So about 70 to 75% success rate reported. If it's thrombotic APS, it's a full dose, therapeutic dose of heparin plus aspirin. So aspirin plus heparin. Okay? But still with this, some pregnancies fail. And there are situations which can predict, and a good pregnancy outcome predicts a good outcome the next time, and vice versa. What can you do? Hydroxychloroquine. Everyone agrees that you should add hydroxychloroquine. Rest of it is controversial. Options: increase heparin dose to full dose, add low dose prednisolone, or use IVIG. ACR-ULAR guidelines have a little bit of difference about what to do, what not to do. Multiple algorithms have been put up. My personal practice is I start with low molecular weight heparin, aspirin, and hydroxychloroquine to start with. If they fail, I'll increase the dose of low molecular weight to therapeutic dose. If they still fail, I'll add prednisolone. Personally, I'm not in favor of IVIG or plasma exchange. But there is some literature and some people do use it. Remember that in addition to obstetric problems, other complications can happen in presence of APL. Mother can get thrombosis. There is this risk of preeclampsia, HELLP, and even CAPS during pregnancy. Remember the post-delivery monitoring. There is higher risk of thrombosis in future compared to normal women, especially if there is a concomitant CTD and additional cardiovascular risk factors. Aspirin is recommended for high risk profile patients and Plaquenil if there is lupus. I think I'll skip this. In the interest of time, we talk about the second important scenario, high-risk pregnancy, neonatal lupus syndrome, which is fetal manifestation of a transient passive autoimmunity. So this is maternal antibodies crossing placenta after 16 weeks, causing transient problems in the child because the maternal antibodies cleared off by 6 months to a year. So neonatal lupus can be rash, cytopenias, transaminitis, it clears off. But problem happen if these antibodies affect fetal heart, and then you get heart block, which is the most feared complication. Up to 2% of exposed pregnancies only. But if one mother has one child with CHP, the subsequent risk goes up to 16 to 20%. So why? There is literature coming out that there is a subset of specific antibodies, not any anti-Rho, and there's some new recent studies about which subset. This is a developing fetal heart. The damage caused by these maternal antibodies leads to fibrosis, and that leads to conduction defect, and that becomes a permanent damage. So it's a permanent consequence of a transient phenomena. And there's some genetic contribution from the fetus as well. Polymorphisms in some genes have shown to increase the risk. A lot of time it happens between 20 to 24 weeks, but other time periods during pregnancy are also at risk. We hope to pick it up early so it can be treated, but a huge majority, 80%, are only picked up when it's a complete third-degree heart block, when no treatment of benefit exists to date. Be aware, a lot of these women can be asymptomatic carriers. So if ever there is a child with CHP, mother should be screened for autoimmune diseases. Not only CHP, there are risk of other cardiac complications and mortality. 20% die. Rest of the 80% of the survivor requires pacemaker, and there are a lot of risk factors which are associated with higher mortality in the baby. What can we do about it? Early diagnosis remains the mainstay. Fetal echocardiography weekly between 16 to 26 weeks because this is the highest risk period, and then bi-weekly. There are other modalities that have been developed because, as I said, most of the time we picked up at third degree when it's too late. So there's been attempts to develop more sensitive tools which can detect septal signs of development of CHP, but as of now, they all remain research tools. One tool that might change the whole dynamics and is being studied is home Doppler monitoring. Twice weekly fetal echocardiography is labor and time intensive, very expensive. This particular tool that is in development is home Doppler monitoring, where mother does twice daily home monitoring. If there is any abnormality in the rhythm picked up, then they go for an early echo. And the smaller study, initial study showed only 5% false positive, which is good, and no false negative, which was very reassuring. So there is an ongoing study, a large-scale study to see, and if this tool becomes available, then it will be a game changer because then you can do home monitoring for these pregnancies. Treatment, controversial. Fluorinated corticosteroids, previously we thought they may help, but we now know that early treatment may prevent progression, but no benefit once third-degree block has developed. Beta agonists for fetal bradycardia, IVIG plasmapheresis have shown some benefits, small studies, but only case report material. Again, algorithms, you can look it up. Prevention. Retrospective data that hydroxychloroquine works, and a large-scale prospective study has shown that if a mother with a prior child with CHP and positive Rho antibodies was given hydroxychloroquine 400 milligram, not weight-based dosing, they have significantly reduced risk of development of CHP in the baby. So 16 to 18% historical risk, 7.4% in this patch study. So in a nutshell, if it's high disease activity, defer, low disease activity, proceed with pregnancy, continue hydroxychloroquine, Rho-Enla, hydroxychloroquine, APL, aspirin, low molecular weight heparin, hydroxychloroquine. So that's about it. And I will not talk about fertility and ARs because we have run out of time. Thank you very much and happy to answer any questions.
Thank you so much, Dr. Aisha Lateef, for such a comprehensive and insightful talk.
Our next keynote speaker is Professor Laniyati Hamijoyo, Consultant Rheumatologist at Hassan Sadikin General Hospital and University, Indonesia. Today she'll be presenting on dealing with tuberculosis in SLE for better outcome. This session is particularly relevant for rheumatologists managing lupus patients in regions where tuberculosis remains a significant challenge, and it promises practical guidance for optimizing patients' care. Please join me in warmly welcoming Professor Laniyati to the stage.
Thank you very much. I would like to thank the organizing committee to give me chance to talk at the wonderful conference here in Pakistan. So my topic about the dealing with tuberculosis in systemic lupus erythematosus for better outcomes. I would like to share with you what we have done in the last 5 years dealing with the tuberculosis in our lupus patient. So this is my outline. So I would like to start with the burden of tuberculosis. As we know, in the Global Report 2024 by WHO, they report that around 10.8 million cases of tuberculosis in year 2023. And the incidence rate is 134 over 100,000 population. And the highest TB cases reported from Asia continent, like in India, Indonesia, my country, China, Philippines, and as well as Pakistan. So I think we all the same face the problem of tuberculosis. So we know already that how the tuberculosis transmit Mycobacterium, and then some of the patient can go clearance, but the other one can go for the latent tuberculosis, and then 10% with a lifetime risk for reactivation of tuberculosis. And some of them also get extrapulmonary tuberculosis. So I would like to start with the prevalence of tuberculosis in SLE. Actually, the risk of tuberculosis around 4.9, and we found out based on the literature is around 5 to 13.7% of tuberculosis among SLE patients, and it's higher in country with the endemic tuberculosis. So we conduct this meta-analysis, then we found out that higher number in patient with tuberculosis in higher burden country like Indonesia as well as in Pakistan. And this study showed that actually the incidence is quite high. I mentioned a while ago that 134 over 100,000 in common population. But in SLE patient, we can see here is higher. Even in India, the incidence is around 2,450 over 100,000 population per year. So we conduct the study in our cohort involve 1,278 patients, and we found out that around 131, so almost around 10% of our lupus patients develop tuberculosis after they diagnose as SLE. So for the incidence, if we calculate it, is even higher than India for above 4,800. So means that we face the problem of the tuberculosis in our lupus patient. So what is the risk factor actually for the tuberculosis in our lupus patient? We found out that when they diagnose in young age, less than 25 years old, they have household TB contact, and as well as they have pulse of methylprednisolone. So the risk becomes higher. And previously, we have done some literature review about the risk of infection in our lupus patient. And based on this literature review, we found out all the risk factors of the tuberculosis in our lupus patients. as high disease activity, renal involvement, high cumulative doses of glucocorticoid, lymphopenia, longer disease duration of SLE, as well as past history of tuberculosis. But recently, we conduct this study and as a case control study to see actually the real risk factor in our center. And we found out the dose of steroid, lymphopenia. However, the duration of SLE, even the shorter period, less than 9 months, becomes the higher incidence of the tuberculosis. So higher the risk of tuberculosis. And the previous meta-analysis, I can show you here, the mean cumulative doses of glucocorticoid in TB patient is higher compared with the cumulative dose of steroid using in patient without tuberculosis. And also, if they get the pulse of steroid, they have the higher risk of developing tuberculosis. So we blame on the steroid actually. Then based on the study showed that if current use of glucocorticoid can increase 6.8 times developing of tuberculosis. And if you use the higher dose and also increase, then the other study by Professor Lam in Hong Kong showed that each gram of prednisolone can increase 23% of developing tuberculosis, and in 1 year cumulative dose more than or equal to 3 grams of steroid and increase almost 18%, 18 times of developing tuberculosis. So, based on this, I would like to clarify that is it because of the disease itself or because of the steroid? So let's see the review, this one done by a colleague from Thailand. And I would like to show you how the tuberculosis, immune response in tuberculosis. So when somebody inhaled the mycobacterium, it will be presented by the dendritic cell to the lymph node in the respiratory tract, and also increase the activation of CD8 and destroy the infection cells, and also release some of cytokine like interferon gamma and also the TNF alpha and IL-2. And by the time also the CD4 activation and proliferation, and also activate the TH1 and release the cytokine like interferon gamma, TNF, or also IL-2. And we know that interferon gamma here can activate the macrophage to phagocyte the mycobacterium and killing intracell the bacterium. And the other hand, interferon gamma and TNF alpha also work to form the granulome product here. So the patient becomes latent. And when the cytokines go down, then probably it's activate the tuberculosis in latent TB patient. So if we see the immune response also here in SLE, they have also activate all the cytokines work almost same as the cytokines work with tuberculosis infection. So by this, we can see that when it is immune-mediated complex, they make a flare or inflammation. They also increase the cytokine like interferon gamma as well as TNF alpha. So with this, actually there is another study in mice showed that if we increase the inflammation, like they provide the LPS to the mice and increase the inflammatory cytokine, and the mice can be protected to tuberculosis for about 6 months. So by the time they increase the cytokine, they increase the inflammation, actually protect for the tuberculosis. However, if you use the steroid, then it's decreased. So that's why we would like to blame on the steroid to cause the tuberculosis. So we conduct this study to see is it steroid or actually the disease activity becomes the risk of tuberculosis? So we use the SAT6 or CFP10s in the IGRA test, the quantiferon test, and we would like to see the production of the cytokine. We compare the patient in the group flare, having low steroid, having high dose steroid, or newly diagnosed, compare with the control one, and we check of the production of the interferon gamma. So I would like to show you here the steroid dose in the group with the flare is around 13 in milligram per day, low dose 3, and then the other high dose. Yeah, but the SLEDAI, we can see here, the newly diagnosed with the highest SLEDAI score. And what we found here, that you can see here that the median TUB1, the interferon gamma production that we test from the TUB2 of the IGRA test, is lower compared with the healthy control. You can see here, it's significantly lower if compared with the healthy control. Means that the production of interferon gamma becomes lower in patient receiving corticosteroid compared with the patient with newly diagnosed with high disease activity. So we also test with the Luminex to see the interferon gamma, IL-12, or also chemokine, and it's also same, show that they decrease the production after they receive the steroid. So with this, I would like to convince you, but because of the steroid, the patient becomes immunocompromised, because you can see here how the corticosteroid reduce the inflammation by suppress the activity of phagocyte of the pro-inflammatory cytokine, affecting also macrophage and monocyte, and also inhibit T cells as a production by CD4 and CD8. So it's reduced the production of the interferon gamma. So that's why back on the recommendation by EULAR that it's better to use the steroid for the very short period and to control the disease activity, and tapering as soon as possible to very low dose, less than or equal to 5 milligram, and discontinue it if it's possible. So for this, we agree that less steroid use can decrease the risk of the infection, especially tuberculosis. So how about the extrapulmonary TB? I would like to let you know that we see here that in lupus patient, we have conducted a study show that extrapulmonary TB is higher compared with other population. And in our study, we also found out that almost it's around 44% of our patients also develop the extrapulmonary tuberculosis. And 9 or almost 10 of them died during the period of the infected of tuberculosis. So with this, I would like to show you that how it's quite difficult in our country or also in your country because of the tuberculosis. Sometimes the manifestations mimics to the SLE itself. Like for example, prolonged fever, we can also found in the SLE as well as in the tuberculosis. Pleural effusion or pericardial effusion. Sometimes you think it's TB, but it's a part of the SLE, even meningitis. Yeah. Then, yeah, it's challenging for us as clinicians to decide this is the TB or this is the SLE or this is the SLE patient developing tuberculosis. So sometimes we want to use some clue, but you may appreciate that if you test patient with positive or active tuberculosis, sometimes the ANA test also positive. Not only for SLE, but in tuberculosis, also positive for the ANA test. And even in other studies show the anti-DS and DNA also can increase in TB patient. So here I show you the study from Shen et al. They show the TB patient has increased the autoantibody. And also the other study here show that anti-dsNA in an active pulmonary tuberculosis patient also increased 60% compared with the 4% in healthy population. So means that be careful when you check for the ANA in a patient with suspected of tuberculosis. Sometimes they can be positive. So based on this, in APLAR consensus statement for management of SLE, we state here that active tuberculosis should be excluded before immunosuppressant, but we have no enough data to treat the latent tuberculosis in lupus patient. So for this, I would like to get some information from these articles done by Professor Tanaka. They mentioned this: if you have a lupus patient, then try to rule out the infection. But if you can suspected tuberculosis, try to finalize if there is latent tuberculosis or not, and then treat the latent. However, this is very difficult. What we done here, we tried to check for the IGRA test in our lupus patient. We found out that in active lupus patient, we can see here the higher number of indeterminate result of the IGRA test. So make the test of IGRA in lupus patients also challenging for clinician. So if you see here, if you use the TST, it can be false positive by the BCG vaccination, and also if the patient have NTM, it's also false positive. But the IGRA is better used if the patient without the steroid cannot affected by the BCG vaccination. However, in the patient receive steroid, sometimes false negative for the tuberculin skin test. And once again, for the IGRA test, sometimes becomes difficult when the patient in immunosuppressive or in high dose or in the high disease activity. So it's also challenging for us. And our literature research showed that in a study by Mok et al. In Hong Kong, they noticed that if you provide the prophylaxis for the patient, sometimes it's not really useful, but increase the problem of liver toxicity. But however, the study by Gaitonde in India, they found out that it's helpful actually prevent the tuberculosis in lupus patient. So should we provide the prophylaxis to our lupus patient? Actually, it's also have a lot of problem because lack of evidence. And we also have known the side effect of hepatotoxicity, neuropathy, and also drug-induced lupus. And yeah, you know, your patient in the beginning, they have so many drugs to consume, and then you add another prophylaxis together with the vitamin, and then they have so many drug interaction, as well as the adherence or not to the prophylaxis. It's all got the problem to how we prophylaxis, how we prevent the tuberculosis in our lupus patient. So with this, we would like to try to convince that its INH prophylaxis is useful or not. So we conduct this study, involved 20 SLE patients with pharmacokinetic data after 10 days taking the INH prophylaxis, and because the interaction of the medicines in our lupus patient, but we found out that the AUC or Cmax is a sufficient level to protect and also save. There is no, after 10 days taking this INH, we didn't see any of increase of liver function test. So with that, we conduct, this is very small study of the safety INH in our lupus patient. We do it the blind control group with non-INH, and then the other group with INH. We involve around 30 patients in each group with the mild disease activity. And we follow them up after 9 months, and then we see here, we conclude that the providing the INH is still safe, not increase any liver function test, but the patient developed nausea and also vomit after taking the INH. But it's really safe. But we need the further bigger study to convince that it's effective to prevent the tuberculosis among our lupus patients. So how about the BCG? Here we see the BCG providing in some population, but the BCG is attenuated life, so it's not recommended to our lupus patient with a lot of complication. So let's wait for the next TB vaccine now in the phase 3 trials. And this one is not live attenuated, but is immunogenic fusion protein. And it show in the phase 2 trial show that it helps to reduce the incidence of tuberculosis around 49% after 36 months. So we still wait for this finish the trial to be used in our population. So by this, I would end my study with the very old one study done by Professor Feng Pausi from Singapore. He mentioned that if you see the patient with prolonged febrile episode, cough, sputum, or dyspnea and weight loss, or unexplained pulmonary infiltrate, lymphadenopathy, pleural effusion, or ascites, try evaluate aggressively and don't only think of the SLE itself, but also try to look for tuberculosis or any other infection in our patient. So try aggressively to also look for tuberculosis in this patient. So with this, I would like to summarize that the relationship between tuberculosis and SLE is complex and may be mutually confounding. And risk factor of tuberculosis in SLE patients, as I mentioned, that methylprednisolone pulse therapy, high cumulative dose, and high disease activity, renal involvement, younger age diagnosed SLE, lymphocytopenia, TB household contact, and past history of tuberculosis become the risk factor. Be careful. And the short-term use of steroid to control disease activity, taper to less than 5 milligrams as soon as possible, and discontinue it if possible. And diagnosis and management of tuberculosis, including prophylaxis, in SLE poses the special challenge, especially in TB endemic country like my country and your country here. And with this, I would like to quote this one. You treat, this is from the movie Pets Adam, maybe it's old movie, but it say that you treat the disease, you win or lose, but you treat the patient and treat the person, you always win no matter what the outcome. With that, I would like to thank all my colleagues who work for this tuberculosis from University Pajajaran and Radboud in Netherlands, as well as in Otago in New Zealand. Thank you very much for your kind attention.
Thank you so much, ma'am, for this compelling presentation.
Our next keynote speaker is Dr. Behram Tariq, consultant nephrologist and consultant in general internal medicine at South Tees Hospital, NHS Foundation Trust, United Kingdom. He serves as a clinical supervisor for IMT. He brings a wealth of expertise in managing complex renal and systemic autoimmune conditions. His presentation will be on update on guidelines and emerging therapies in lupus nephritis. Please, everyone, kindly give a big round of applause for Dr. Behram Tariq.
Hello. Good morning, PSR. Thank you very much for having me. It's an absolute pleasure to be here talking to you guys. I'm Dr. Behram Tariq. I'm one of the consultant nephrologists, and I'm coming from the northeast of England. I am not alone today. I'm not feeling left out. I'm not only the nephrologist today, I've just seen Ahad sitting in the front row. Hi, Ahad. So today I'm going to be talking about the update on guidelines and the emerging therapies in lupus nephritis. So I have no disclosures today. What is lupus nephritis? So lupus nephritis is basically one of the severe complications of lupus. It has got a high mortality. It has effects on renal survival. It can cause patient to end up having end-stage renal disease. And also it has, if it is left untreated, it can cause quite bad consequences for the kidney and for the patients. It is treated with standard therapy, immunosuppressions. It has a risk of relapse, and it is difficult to treat. It carries a lot of disease burden. So to start with, we're just going to quickly talk about the different types of lupus nephritis. It starts from different stages, from stage 1 to stage 6. It affects the mesangium from a very little level to a higher level, from a mesangial change to advanced sclerosis. And the advanced sclerosis is where the kidneys don't have any reversibilities. And it can affect the kidneys in multiple ways. The most commonest presentation that I see in clinic is the type 3-4, where they present sometimes as a crescenteric glomerulonephritis. So it presents to us with a wide variety of pathophysiology and pathology. So how does lupus nephritis affect patient survival? We have seen from a Euro-lupus cohort and from another cohort in France that it has an effect on the survival. And you can see from the lupus Euro cohort study, the survival from 90% goes down to 70%. And how does it affect on the mortality of the patients? The mortality, there was a study conducted in France which looked into patients who had disease, and renal failure was one of the cause for these mortality. So patients who have lupus and when they develop lupus nephritis, they both have an effect on their survival graph as well as their mortality. There's another single center retrospective observation which was carried out in the University College of London. And it also showed us that the 5-year survival rate at the point when the patient was under the nephrology team showed 90%. And by 20 years follow-up, the survival got down to 60 to 70%. So we have updates in these guidelines. And what does these guidelines say? We have KDIGO, we have ULR, and we have ACR. In summary, and the key novelty that I have taken from these guidelines are that we have to emphasize on early diagnosis, tailored immunosuppressive therapy regimes, regular monitoring to improve renal outcomes and prevent progression to end-stage kidney disease. We're going to talk about the different recommendations by these guidelines, and I'm going to focus here on KDIGO because I'm from the United Kingdom and we usually follow the KDIGO guidelines. I am actually delighted to know that our previous ex-speakers have emphasized on the role of hydroxychloroquine, so thank you very much. Hydroxychloroquine, we have started using them irrespectively of whatever stage of lupus nephritis they are. And there is 1C grade evidence for the use of hydroxychloroquine, particularly for having an effect on declining the lupus nephritis flare. And we have recently seen some observational studies that it has also effect on the eGFR of patients. Lupus nephritis 1 and 2 is very common, and we sometimes don't, when we see them, they're already been seen by yourselves. And when they come to our clinic, they are already on some form of immunosuppressions. And we have 2 stems to treat them. And the guidelines and the recommendations suggest that we should be treating them either if they have proteinuria or they have minimal change disease in the form of heavy proteinuria. If they have, it is to the discretion of the consultant nephrologist what choice of immunosuppression they would use. But they are very responsive to steroids, and they are exactly as minimal change disease. I have 2 patients who responded complete remission with just steroids only. This is the most important slide, and this is where the new guidelines and emerging therapies have been suggesting where we go from here. The induction therapy for class 3-4 with membranous component, and this should be an active class 3-4. We know the conventional therapy for class 3-4 active glomerulonephritis by SLE is nowadays we're going to do pulse IV methylprednisolone. After that, you decide two ways, whether you want to continue with cyclophosphamide, a higher dose or a lower dose. The higher dose goes to about 6 months and the lower dose is for 3 months. And then you can also choose to use MMF. Then we have these new alternatives, KDIGO suggestions of what we should be doing in terms of the global use of triple immunotherapy regimes. And we have changed our paradigm of using dual immunotherapy now to triple immunotherapy. A lot of my colleagues in my trust are using triple immunotherapy regimes at the moment. So KDIGO suggests that we can use on top of the standard induction therapy, which is cyclophosphamide and MMF, either with each one of them, you can add belimumab, voclosporin, tacrolimus, rituximab, or azathioprine. And all these recommendations from the guidelines got 1B scoring. Again, I'm thankful to my previous speakers who have emphasized on the role of the use of steroids. We don't like steroids. We have seen in a majority of our patients who have ended up with having severe complications in the form of infection, bone thinning, ending up having diabetes. And I will be the most unhappy nephrologist to see our CKD patients developing diabetes. So what is the consensus and what are the guidelines saying for the recommendation for the use of steroids? Both KDIGO and as well as EULAR are now emphasizing on the fact that we should be using the lowest dose of corticosteroids and then wean it down as quickly as possible in the first 6 months. And the maintenance dose should be around 5 milligram or lesser, depending upon patients' demographics or ethnicity and their body habitus and their previous risk factors. So this is an important slide, which is an important home takeaway message about the use of corticosteroids. The paradigm is shifting when we should be using the lowest dose of steroids as possible. This recommendation received a 1B grading from the evidence and the summary from the KDIGO guidelines. So KDIGO gives us 3 regimes: the high dose regime, the moderate regime, and the low dose regime. You can pick your own choice, and it depends again on the discretion of the treating physician. If a patient is presenting with severe lupus nephritis in the form of glomerulonephritis, which is rapidly progressing, then we usually use the high dose regime and vice versa. So we talk about the maintenance. What are the guidelines and the key home takeaway messages for lupus nephritis by KDIGO? So once they have had an induction for 6 months, we're going to use maintenance therapy. Grading from evidence-based practice is 1B for all these medications. The first line that I use and my colleagues use is MMF. If there is any particular reason for which we cannot use MMF, we would then consider switching it to azathioprine. We can switch it to tacrolimus. We can switch it to, recently the new added on guideline from KDIGO is that we can continue the triple immunosuppressive regime as what we have done in our induction. The important thing, again, is to look into the maintenance therapy. And this is very important for us nephrologists because we don't know what the outcome is for that kidney after 3 years. And for me, it's more important that I preserve the kidney functions and I preserve the patient's graph of eGFR so that we do not want them to end up having end-stage renal disease. So where I am with that. KDIGO suggests that we should be treating these patients for 3 years. And what about the corticosteroids? The corticosteroids are mainly used for extrarenal manifestations. We have now started to discuss with our patients early enough to discuss whether we should be weaning these steroids after 12 months once they have a complete remission. Again, this is another schematic diagram showing what the KDIGO guidelines suggest. Particularly, I have a few patients which we have started based on this multi-center study in China by the use of MMF and tacrolimus. If we do so, we put them on a low dose of MMF. So 3 of my patients have been now put on low dose MMF and tacrolimus as first line to carry on the triple immunosuppressive therapy regime, and they are responding very nicely. So we go to the treatment of pure class 5 lupus nephritis, and this, the data and the guidelines suggest that we only treat these patients if they have a certain degree of proteinuria. If the proteinuria is 1 gram per gram, they get their treatment as in terms of immunosuppressions. What is the choice of immunosuppressions in class 5 is again at the discretion of the treating physician. And they can start the immunosuppressions with corticosteroids along with MMF or cyclophosphamide or a CNI or rituximab. I think this is a very important slide, and this is also something I'm going to emphasize on the home takeaway message. So when we treat these patients, we need to really see what the response is. And how is the response defined is basically this time KDIGO, thank you very much, have given us a nice definition of what the response should be. The response can be achieved in the form of partial response or a complete remission. We should be seeing a complete remission or a partial remission from month 6 to month 12. If a patient presents with whatever degree of proteinuria, in the first 6 months to 12 months, if they have, with the treatment, had a urine PCR of 0.5 gram per gram, we would call them as complete remission. If they ends up having a partial remission, which is defined as 50% of reduction in proteinuria from the start where they presented, and there was no significant change in the eGFR, then we would call them as partial response. If a patient is having partial response, we will continue them to observe for the next 12 months. This is another schematic diagram from the KDIGO showing about what complete responses and what partial responses. So, going now to the therapeutic biologics, everybody is talking about them. What are the new boys in town, I must say. So there are 2 new novel therapies that are actively being used in the UK. One of them is belimumab and the other one is voclosporin. We know that the pathophysiology of lupus nephritis plays around the hyperactivity of B cells. And there are other cascades of the immune system which plays a particular role. So let's talk about belimumab, because why am I going to talk about belimumab is because this is recommended in the KDIGO guideline. And what is belimumab? Belimumab has been with you guys, with the rheumatologists for decades. We have recently started using it since 2022. It affects B cells. So the trial that was conducted was called BLISS-LN. There was randomization of belimumab versus placebo with the use of belimumab versus standard of care therapy. This trial was conducted for 2 years. And what was the end results? We looked into the partial response and the complete response. As comparison to belimumab and placebo, patients who received belimumab had good partial response as compared to placebo, and as well as complete renal response as compared to placebo. Another quick slide, which is the same results. You can see the graphs are wide apart, where patients who received belimumab had 43% partial response and 30% complete response as compared to the placebo group. What was the safety profile? Belimumab was rendered safe, and there was no significant hazards. What is the other drug? It's called voclosporin. Voclosporin is a calcineurin inhibitor, and it acts on the T cells of the immune cascade. Where does the guideline comes for voclosporin? It comes from this trial called Aurora 1. Aurora 1, basically we had randomization of patients to voclosporin arm and also to the placebo arm. This trial was conducted for 1 year, and the end outcome results were to see complete renal response. What were the results? The results were that the use of voclosporin had an impact, positive impact, having complete renal response 41% as compared to placebo, and there was also a rapid reduction in proteinuria. So from 1 year onwards, the Aurora 1, when we had good results, the team from Aurora suggested to carry it on for another 2 years. So patients who were randomized in Aurora 1 trial, they were the same cohort in Aurora 2 trial. 357 patients in Aurora 1, there were some left outs, and 216 patients were randomized in Aurora 2. This slide is very important. What does this Aurora 2 trial outcome suggest? 3 points. It showed us how safe and effective voclosporin is in total 3 years' time. Because as a nephrologist, I would know what is the long-term outcome for my patients with their kidneys. Number 2, I know that voclosporin now has a good effect on the eGFR. So there was not a significant drop in eGFR, and it had been very stable. The last one, all we know that proteinuria, as per our guidelines and evidence-based practice, is a single independent marker of mortality and an independent marker of end-stage renal disease. So patients, when you or I treat, if they have heavy proteinuria, we need to make measures to improve proteinuria, not only to achieve their partial or complete response, but to save their kidneys' health in the longer duration. Another important slide. I get phone calls when I'm on call, or I get referrals. Dr. Tariq, would you biopsy this patient? Of course I would. But when? And what are the importance of having a biopsy? So let's say a patient that I see in clinic presented with signs and symptoms of SLE. We know they have biomarkers positive indicating SLE. I will biopsy them if they have significant proteinuria. And I will biopsy them if the first presentation is with reduced eGFR. But when to biopsy again? These recommendations are now in KDIGO. If I'm treating a patient and the patient has got a refractory lupus nephritis, I will consider a biopsy. If I have a suspicions of lupus nephritis, I will consider a biopsy. And why do I need to consider a biopsy? Is because I want to see how active the inflammation is within the glomeruli. Can I change the immunosuppressive regimes? Can I increment the immunosuppressive regimes for the patients, or should I just continue with the same therapy? Now there's a big debate going on Twitter about protocol biopsies and whether we should be doing or not. Protocol biopsies are mainly conducted, and there's a big shift in the United States. They are conducting them with triple immunotherapies. If a patient is responding and they reach 3 years as a complete response and their disease activity is dormant, if they want a biopsy, yeah, go ahead. If everything is dormant in the tissue, you stop immunosuppressions. So a biopsy at the end of 3 years may be helpful. Can we do a biopsy just to see if we have to increment or decrement their immunosuppressants? Yes, we can consider that. Again, this will all be in the discretion of the treating physician. This is an important slide. I know there's a lot of cartoons and everything, big, busy slide, but focus on the very bottom there. We have seen patients, when we biopsy them, biopsy 1, biopsy 2, biopsy 3. Why have we done 3 biopsies? Because 1, they presented with possible lupus nephritis. 2nd, whether there was a flare. 3, whether there was chronicity. Having lupus nephritis itself is a marker of damage to that nephrons. But what are we going to do? Because how long is this kidney going to last if the patient has a lot of immunosuppressive burden, if they have metabolic syndromes, if they are having diet very rich in carbs, if they are on steroids, and they are developing type 2 diabetes? That's add-on risk factors. I would really want the resident doctors here, particularly who are seeing the patients on a day-to-day routine, on their ward rounds, irrespectively if they are rheumatologist or nephrologist. Patients who have metabolic syndrome should be on or high blood pressure with proteinuria should be considered for ACE inhibitors and also for SGLT2 inhibitors. And believe me, I am loving SGLT2 inhibitors for all my CKD patients. It has proven really, really efficacious and safe. Obviously, we have to avoid type 2 diabetes and consider asking them to stop alcohol or smoking. What are the other new therapies? So, there's a lot of talk and debate about CAR T cells. Do I use them? No. Do my colleagues use them? No. Have somebody in the UK use them? I don't know. There are these trials which are from America. One publication was a 2-year result showing 100% complete renal response in 3 months, and there was no relapses. The other publication was in a big Nature Medicine journal, was 5 cases of refractory lupus nephritis who received CAR T cells, and they went into remission and had very minimal side effects. I'm sure your colleagues would have already touched on this new other drug, obinutuzumab, and it has been recently published, and it has been recently suggested to be used. Do we use it? No. We haven't started using it yet. The efficacy and the safety profile is quite good as well. The only thing that we have noticed, just like with steroids, there's a higher incidence of infections. And then there is a wide plethora of new drugs that are in the pipeline. Big companies have invested in immunobiologics. The drugs that are encircled in red, they are either published or soon to be published. The drugs which are encircled in black, they are soon to be published in the next 3 years or maybe half a decade. I'll emphasize here that we are not only focusing here on B cells, we are focusing on T cells, we are focusing on DNA remodifications, we are focusing on interferons, and you tell me every cascade of the immune system that we have. Yeah, I have to put this slide. This is one of the trendiest and viral slide in the Twitter community amongst the nephrologists, and it's actually the same what I've told you in my X slide. It's very important to talk about the cost and access considerations. I, as a nephrologist from the United Kingdom, I look into cost effectiveness. Do I use these new drugs, belimumab and voclosporin, in my day-to-day practice? No. I have not used them as yet. If I have to use them, I'll have to have an MDT. I'll have to speak to the regional lupus nephritis team. We have to take on board the infection disease team. And we have to do a lot of paperwork to get the special funding. And at the cost of what? Spending thousands and thousands of pounds. I know these are drugs which are recommended. They are on NICE guidelines, and they are also FDA approved. But I have to be very careful in my decisions and the impact of these drugs for my patients. So, what is my 2 cents take after all this discussion as a nephrologist? Believe me, I don't know. I still don't know what is the long-term prevention strategies for my patients who have CKD and end-stage renal disease beyond 3 years. I still don't know what is the optimal therapy for severe lupus nephritis. All these trials had patients with eGFR 30 and above. There's a lack of data, and more data is needed in class 5 lupus nephritis. Cost. We are struggling in the UK. What about the low socioeconomic countries? Quick one. This is the summary for my presentation today. We've spoken about diagnosis, biopsies. We've spoken about 1, 2, 3 class of lupus nephritis. Thank you very much to the ex-speaker who spoke very brilliantly with the pregnancy in lupus nephritis. I think the most important is to take away these messages. Please, please, please look into the metabolic factors. Low salt, blood pressure control, dyslipidemia treatment, exercise, low carb diet. These are something that we can change at early stage of our patients. Long-term success, what does it depend on? We know there are a horizon of medications coming up, but it is overcoming safety concerns, improving response durability, and ensuring access to care. 2 minutes here, please. Last but not the least, our patient's perspective. Whatever we do, we have to deal with our patients. Please, when you are at your leisure time, go through this video. She's called Jeanette Anderson, and she did a roundtable conference in UK Kidney Week 2024. She herself has lupus. She is a co-author for a lot of citations with Euro lupus community. She has written a lot of guidelines for ULR and as well as KDIGO. So she is a living example of lupus nephritis patient. And what did she say in her speech is that we hope for a better life. And I'll end up here saying that I think whatever we do is we should be dealing for the quality of life of our patients, do all efforts to improve their quality of life and give them a hope for their better daily life. Thank you very much.
Thank you so much, sir, for such a wonderful presentation.
For our next keynote speaker, we have Dr. Tahira Parveen Umar, Head of Department and Assistant Professor of Rheumatology at Liaquat National Hospital, Karachi, Pakistan. Today, she'll be presenting on juvenile lupus, transition care, classification criteria, and pediatric updates. This session will provide critical insights into bridging pediatric and adult care updates on classification criteria and practical approaches to managing juvenile lupus. Please join me in warmly welcoming Dr. Tahira to the stage.
Assalamu alaikum. Thank you so much for your kind invitation, and especially after having such an elaborative and beautiful pediatric review session yesterday. We had brilliant talks, and I'm sure most of the things were covered yesterday. I congratulate the organizers, especially their mentor, Dr. Nighat, that they have organized a wonderful conference with a very detailed scientific program that addresses each and every topic. You have heard beautiful talks, and those who came late, I assure you that you have missed 3 beautiful talks about lupus. Mine is very simple, as most of you are adults, so I'll be focusing more on the basics, and some of the details are for the junior residents. So I'll go through my talk with transition care, classification criteria, and pediatric treatment updates. So by definition, the childhood lupus is in the patients where the disease onset is before 18 years of age, and it accounts for more than 15 to 20% of the total population of lupus. Transition care is not a single event. It is a process that empowers young people with lupus to take ownership of their health and thrive into adulthood. Now, this is not the problem of our country, actually. Luckily or unluckily, we do not have pediatric rheumatologists here. So adult rheumatologists are taking care of pediatric population as well. But we really hope that we do face this kind of problem in near future, inshallah. So it is a structured process preparing the adolescents for adults, adult healthcare, because the pediatrician, they treat their children and their parents like a baby because they are already baby. But the adults try to treat them and handle them like an adult, which is a big change in the life of the patient and the parents as well. So the transition care is very important, so the continuity of care stays there. It promotes independence and self-efficacy of both parent and the patient, ensures treatment adherence, and address psychosocial, educational, and reproductive health needs. We know that there are a lot of bodily changes, hormonal changes are happening at that time. So the child is already going through a lot, and at the same time, they have to, shift their physician, change their physician with whom they are, attached with. So it's also affecting them, their psychosocial status. So as with other diseases, early planning is very important. It starts not at the adolescence, but at the age of 12 to 14, we have to initiate the discussion, continue to educate them about their disease, and we do have to do it repeatedly. In my clinic, if my peds patient is 10 years old, I try to talk to them directly, ask them directly, and even if the patient is younger, so that they become, they start verbalizing their problems. Because in the future, this is what my counseling is, that although the family is suffering from their disease as well, but this is the patient that have to go through everything, all the burden, all the medication taking. So they have to take the charge of their disease sooner or later. So we have to prepare them from the beginning. Rheumatic conditions, they already have got multidisciplinary approach, but in here we've got another person, pediatric rheumatologist, along with adult rheumatologist who, try to prepare them for their future. Many hospitals worldwide, they have overlap or joint clinics where they gradually expose their patient to the adult rheumatologist and their, body language and behavior. There are different tools and strategies which are used for this transition. Most common one is TRAC, Transition Readiness Assessment Questionnaire. It's not very simple questionnaire, but it is available for both the patient and the parent and the caregiver. It is taken, it is filled by them serially, and this is the sample that we calculate the score. And the higher the score is, it means they are ready to go to the, to the other care. So Croatian people, they converted it into their own language, translated it, validated it, and they found that at 7 years, 81% patient, they followed up in the adult care, but they still, following up, and they included many rheumatic diseases in this TRAC questionnaire. Other tools and strategies were medical summaries, individualized transition plan, because many children, they are so much attached to their rheumatologist or physician that they do not want to go anywhere else. So it takes longer for them. Regular feedback from their adult rheumatologist so that you know that everything is going well. The psychological consideration, which is of the age and, with the disease and the change of the care, we have to address them individually as well, encourage autonomy along with family support. Here in our part of the world, the family stays with the patient throughout the life, but in the outside world, when they are 18, they have to go out and stay alone. This is happening here as well, but when the child goes for their education to the hostel or something, but in Western world, it's more prevalent, more common. So that's why they are focusing on autonomy along with family support. Successful transition is required so that our patient stays in follow-up, there is regular adherence and disease control and enhanced self-confidence and autonomy and better long-term organ and psychosocial outcomes. There is a lot of data that tells us that if the patient is not compliant, is not in regular follow-up, the disease outcome worsens. So it's very important. So there was this data. I showed you initial corrosion data where they said that 81% patient had regular follow-up even after 7 years of their transition. But this data shows something else. They said that even using most of the strategies, and the age of transfer was like more than 19 years, constitutional symptoms increased, medication adherence reduced, there were more missed appointments and ER visits in the patients who were transferred from pediatric care to adult care. So even the structured handover was not flawless and a bad thing happened to our patient. So we have to continue to give ongoing support to our patients. We know the classification criteria. We already had the adult lupus had 3 very beautiful criteria, but pediatric population do not have specific classification criteria. And as with other component of rheumatic diseases in pediatric, we try to reciprocate these classification criteria in our population. But there were certain studies, there were certain data which were conducted to prove the efficacy of these criteria in pediatric population. So this one was published by Aslan Asma, and they included 111 patients, and they tested them at 3 times at the date of registration, then at first year and at the last year. So what they found was that ULAR ACR criteria was it was highly sensitive at the time of diagnosis and first year. Last visit sensitivity was equal between 2019 and the SLIC criteria, but the specificity of ACR criteria was highest amongst all these 3. So we do have significant difference, and obviously we need a new criteria for the PEDS population only. There was another meta-analysis which showed very important facts, actually, that the performance differed between the 2 criteria, and they showed that the global accuracy of ACR 91, global accuracy of SLIC was was better in PEDS population, and performance was of SLIC criteria as far as sensitivity concerned was better. But when the specificity concerned, they said that the score, because the diagnostic score is more than 10 for the SLE criteria in adults, but if they had taken the score up to 13, the specificity increased and it surpassed both of the other criteria. Same goes with the performance, and it was concluded that SLIC criteria was better at first visit and follow-up, but adoption of ULAR ACR criteria with a score of more than 13 was doing better with childhood lupus. Some updates, you have already heard it repeatedly, but we know that childhood lupus is more aggressive as far as its clinical course is concerned. There are more incidents of nephritis, cardiovascular disease, neuropsychiatric involvement, which affects the prognosis. Macrophage activation syndrome is very common in childhood lupus as well. So all these aspects, they affect the outcome, and the standard of care therapies, which include a lot of cytotoxic drugs, which you have been listening to since yesterday and before that, they sometimes are not that helpful. We know that standardized mortality rate is higher in pediatric population as compared to adult. So all these factors, they ask for further development of newer personalized therapeutic approach with reduced side effects. So I will go through individual medications, the groups, with certain refresher for the residents. What is B-cell targeted biologics? We know that B-cell innate immunity, it plays pivotal role in SLE pathogenesis, especially the development of anti-dsDNA antibodies, which has direct effect on tissue damage and dysfunction. Rituximab is the first one and the oldest one of this, and it's a monoclonal antibody. It's not approved for pediatric populations, but it is used in as off-label medication. So we do not have any randomized trial or other trials for this. The usual dose in which it is prescribed is 375 milligram per meter per square per week for the children. And the most common indication is nephritis, neuropsychiatric involvement, cytopenias, and in refractory cases, they have shown good response. So rituximab was found to be an effective add-on in this study. And even after 2 years of infusion, there was good response and in controlling the SLEDAI and the complement level, anti-dsDNA level, and other features like proteinuria, and the cumulative dose of steroids was also reduced in the group which received rituximab. Most important thing that there was no mortality or development of end-stage renal disease in this cohort. But there is another aspect of this medication. The hospitalization rate was increased in children. A cohort of 1,500 plus patients was studied, and out of them, 219 patients got admitted with infection, and 7 children died in the year following. The most common cause of infection was a bacterial pneumonia, sepsis, and cellulitis. 12 of them had COVID-19 as well, but none of them died because of that. So there was a hospitalization rate of 14% of after rituximab in PEDS patients. Belimumab not available in Pakistan, but it was authorized to be used in children by FDA and for childhood lupus and lupus nephritis, and it has shown a good response in a multi-center study presented from China, where they described that the patient can low lupus disease activity score and clinical remission was seen in many children who went through, and the steroid dose was also reduced remarkably over the period of months. Obinutuzumab, it is a next generation CD20 antibody. There are no specific experience in pediatric population, but this was given in certain case reports with good response in the renal disease, especially in some areas. Cytotoxic antagonists, we have been hearing the name of interferon inhibitors, cefalimumab and anifrolumab. It hasn't been used in pediatric population, but in adults, they have shown good response. In TULIP trial, which my friend just highlighted a couple of minutes before, there was not a single child in that trial, so we cannot say that it really worked for them. But they are hiring AstraZeneca, Blossom. They are planning to take some children in for this study. JAK inhibitors, they are new in the market, are being used in various indications in adult as well as pediatric population. It is mainly given in mucocutaneous musculoskeletal manifestations. There was this study published recently which showed that there was clinical improvement in the symptoms. Not all of them, only 9 patients were there, 4 of them did very well, but there was reduction in the dose of steroid need in all the patients. Bortezomib, it is used in multiple myeloma and was also used in some of the patients who had neuropsychiatric lupus with psychosis. There was a case series, and they found out that the patient after Bertuzumab didn't have any further episodes of psychosis, but yes, they developed hypogammaglobulinemia. CAR-T, again, it's very much in nowadays. Everybody is discussing about it, and it seems it is going to help our patients. Has not been tried in pediatric population, but this is what REACT-1, in which this is a phase 1 trial approved by FDA, and they are recruiting patients with childhood lupus in this. They plan to take about 12 patients, and there is another trial going on in China. So we hope that we will get some results soon about its efficacy in PEDS population as well. Mesenchymal stem cell, no data, but theoretically it should be helpful to the patient. When we talk about lupus nephritis in adults, almost everything translates to the pediatric population, but it is said that class 3 patients, they intend to have complete remission more than 4 and 5. Mycophenolate and cyclophosphamide were equally effective, and complement serum creatinine and biopsy classes, they were the predictors which predicted the stable kidney remission. So this is the cartoon which shows all the potential treatments which can be used in childhood lupus, but many of them are still in the pipelines. I mean, under investigation for pediatric lupus. These are a couple of newer treatments: lenalidomide, telitacicept, and these are tongue twister, tepirulizumab. They are still, they are evolving. So we do need innovative therapies and new therapeutic interventions that can rapidly reduce the disease activity and prevent iatrogenic consequences. And we need large, well-designed, double-blinded trials so that we can, put more importantly, newer classification, which is pediatric population-oriented. But this can only be done by fostering international collaboration. Thank you so much.
Thank you, Dr. Tahira. We are now pleased to invite our expert panelists for this session. We would like to call Dr. Ahad Qayyum, Consultant Nephrologist, Behram Hospital, Lahore; Dr. Fahim Usman Sulehri, Head of Department Nephrology, Central Park Teaching Hospital, Lahore; Professor Dr. Ahmed Saeed, Conveyor and President, Pakistan Society of Rheumatology and Head of Department Rheumatology, Central Park Teaching Hospital, Lahore; and Professor Dr. Sumaira Farman Raja, Chairperson, Scientific Committee, PSR 2025 and Head of Department Rheumatology, National Hospital, Lahore.
We would also like to welcome and invite the speakers of this session to please come on the stage for panel discussion and the Q&A session.
So we are really honored to have amongst us Professor Tsutomu Takeuchi, who have come from Japan. Professor Takeuchi is the immediate past president of EPLAR, and this year's meeting, the major landmark of this year's meeting is EPLAR patronage, and this would not have been possible without Professor Takeuchi's your support. Thank you, Professor Takeuchi, for being here, and I would invite you to join us as an expert panel. So, Professor Laniyati, please kindly come. So, Dr. Tahira, Dr. Aisha, Lateef to join.
This has been a fantastic session, and we are so happy that we discussed almost every aspect of lupus which we can do in this short time. Thank you so much of our worthy speakers, and we welcome you all here from all over the globe actually. And with EPLAR platform, this looks like a mini EPLAR right now. Tom, I think your presence here means a lot to us. Thank you so much. And I think हम panel discussion भी करेंगे और question answer भी करेंगे. So we have to do it in a way that our questions are answered, but at the same time we want to decide that how nephrologists, gynecologists, and rheumatologists should come together and treat lupus. I will have to say that, and I think somebody can correct me if I'm wrong, that lupus is treated by rheumatologists. So if a patient with lupus has some problem with his brain, then we get our friends from neurology and we tell them, we need your help. But the patient has to come back to the rheumatologist because it's a multi-system disease. Similarly, if we are sending them to a cardiologist or we are sending them to a gynecologist, they have to come back to the rheumatologist. It should not happen that they just disappear. उनको ये होता है कि अच्छा तो ब्रेन की कोई बीमारी शुरू हो गई है, so rheumatologist का रोल खत्म हो गया. Never. So I tell my patients that we are friends. We are going to be friends for the next 2 decades or 3 decades or forever. So because you don't know when a flare is occurring in which organ. So as I said, it's multi-organ. So we have to remember this. And I think rheumatologists are the one who should be treating them and with their colleagues, whether they are nephrologists, whether they are cardiologists, pulmonologists or gynecologists. Do we agree on this or no? Yes?
Yes.
Yes. Because we don't want to lose them. They're very precious and they can flare up anytime. Because we don't even keep one step forward without a colleague. We will call Ahad, we'll call our nephrologist. What's happening? What are we doing? Let's do the biopsy. Let's treat together. So I think this is the principle. And I think we should not forget that. With that, first the questions and then the panel discussion. Very interesting questions. Dr. Saira, if a patient has achieved 50% response with therapy at 12 months, should we extend the same therapy or change therapy or repeat biopsy?
Thank you.
This question is to Behram, Dr. Behram Tariq. So you would be the right
This is for
person.
Dr. Behram.
Thank you for your question. I think the answer is very simple. If there is ongoing partial remission, we continue the same regime until and unless there is a new change, which is number one, a decline in the EGFR or an incline in the proteinuria. In that scenario, we may consider a biopsy. Again, this is physician's discretion, or maybe we can increment the immunosuppressions. But I would continue the same immunosuppressions for up till 1 more year. Thank you.
And I believe, yes, because the primary, as Professor Nikhat Mir has emphasized, the doctor who would be taking care of lupus patient would be rheumatologist. If there is flare in any other system, so then jointly a decision can be made to escalate the therapy.
I'll come to this discussion about an MDT. So recently we had a patient, she's still in the ward before I was coming here to Lahore. She was 22, she presented with first presentation of SLE, and just believe you me, she's had every complication of SLE, which started from SLE cerebritis. She was intubated, she had immune thrombocytopenia, she had APL low teachers positivity, and we didn't do anything. We just got the rheumatologist on board and we gave them plasma exchange, immunoglobulins. We hit them hard. We gave them rituximab, cyclophosphamide. Believe me, it's not just the nephrologist who does it. We have an MDT, including the infectious disease team, to give us some guidelines and suggestions. So I agree with the panelists and as well as the organizers here, though it's more like an MDT role.
There are more questions for you.
Of course.
And I think this is also very close to our heart. Is from Fatima and Safia and Shaida and Tahira. Could SGLT2 inhibitors be given in lupus nephritis? Could they be given also when they have stage 5 CKD? So
Invite me for an SGLT2 talk and I'll give you all the details about SGLT2 inhibitors. I love them. So SGLT2 inhibitors are indicated in SLE. We have observational studies where SGLT2 inhibitor receptors are found in tissues of these SLE patients. Number 3, we prescribe SGLT2 inhibitors as down as to the EGFR of 15. My practice is any patients who got CKD with proteinuria, diabetic, non-diabetic, I would get them on empagliflozin, dapagliflozin, canagliflozin, depending upon what level of EGFR they are. I hope that answers.
Yeah, thank you. One more for you. Is calculation of EGFR equally reliable compared to lab results provided as EGFR?
Sorry, can you repeat the question?
It's about EGFR. Do you calculate them or do you just rely on the lab which gives you the result?
So our laboratories just give us an already EGFR calculated. So when we have these blood results, we don't do them. It's already an estimated GFR levels from the laboratory, which is how it is done in the United Kingdom.
Thank you so much. So we have to give them, right?
So,
We should give them.
Yeah.
Yeah.
Absolutely, please do. It's not only for SLE, but for every patients who are diabetic, who are non-diabetic with CKD, who have some degree of proteinuria. Strong SGLT2 inhibitors. Thank you.
So my question about creatinine clearance, EGFR, was that some of our labs do give the details, but mostly it's like more than 90, more than 60, then 30, then 20, like that. But when we see data, they say that even like 10, a decline of 10 is very important. So if we calculate it in our clinic, is it equally efficacious or better, or should we rely on whatever the lab is saying?
I think this question is more subjected to the practice which you are doing in Pakistan, and it is not that what we do in the United Kingdom. We already get the estimated GFR, which are very reliable, and we just go on with the EGFR results from the labs which are given. If there are certain scenarios we do have to calculate creatinine clearance, we don't do it in SLE or, the lupus nephritis. There are other conditions where we may consider, but not in particularly SLE patients. Thank you.
Can I add, sir? Of course. Actually, ma'am, when we are prescribing some drug and we have to calculate GFR, then we have to use Cockcroft formula for drug dosing. But when we have to find the stage of the CKD, then we have to use CKD EPI equation. But some labs like Shaukat Khanam use MDRD. But now the latest equation is CKD EPI equation for calculating the GFR. And for drug dosing, we can use Cockcroft formula, which is the past formula we're using for many years.
Thank you.
May I ask a liberty
Can I
of asking
simplify
the
this
question?
even further? Just to simplify, for Pakistani audiences, the EGFR that they will tell you is usually wrong.
Yes.
And the reason behind that is that regardless if you take MDRD or CKD epi or whichever equation they'll take, the denominator is always weight.
Yes.
And they never weigh the patient.
Yeah.
So it is always, the right word would be actually it's wrong. So it is questionable. For you to use these equations, they were made for CKD. They were made for stable GFR. They were never made for changes in creatinine. So you always have to just take it with a pinch of salt, but that is all what we have, so we have to work with it. Yeah.
Okay, isn't it better to just then calculate the creatinine clearance?
If you can do that, that is perfect. And that
Yeah.
is what, standard practice for
Yes.
Pakistan would be.
Yes,
And
exactly.
that's what he's precisely
Yes.
trying to say. That
So
let's do it
creatinine
ourselves.
clearance, and one question which Professor Myra would generally ask, and this is a burning question, is this should be the ideal body weight or the patient's current weight?
It has to be the ideal body weight because there's lots of water in the patient.
Okay.
So you can't calculate that as weight because that's not flesh weight.
Okay. So it's the ideal body
Ideal
weight.
body weight for that particular.
So for our
And
population,
for obese patients, for otherwise if they don't have fluid overload and obesity, so we need to adjust to ideal body weight or their current weight?
Their current weight. then.
Their
Of course.
current weight.
Yeah. Yeah. Okay.
can you clarify that for the audience? Okay.
I'm sorry. So the question is that height help, but height is not in the denominator, not in the numerator. So height wouldn't matter. No. Yeah.
Okay. So for our population, creatinine clearance it's better to calculate that, then to go with a lab EGFR, and it has to be ideal body weight.
Yeah. And again, if the patient is coming to your clinic, so madam, it is just like if he's coming to your clinic and creatinine is 2.2 for 6 months, so you can use the equation, it's absolutely fine, it was made for that. But if you're on the ward round, there is an acute flare, creatinine, one day it's 2, then it's 4, it's 6. Even if the EGFR they're calculating is 22, it's actually 5 because it's changing every day and the patient will need dialysis in the next 3 days. Yeah.
Thank you so much. Hope that's clear. Yeah, thank you so much.
My questions are addressed to Dr. Aisha. The first question is by Dr. Saira, and she wants to know that for how long dexamethasone should be continued in the first and second degree heart block in fetuses?
Yeah, so there are very different protocols that are being used in different centers. Generally, most of the agreed consensus is you try and give it for a week and see the response. If there is a stabilization or improvement, then you continue and start to taper it. But if there's no improvement after 1 to 2 weeks, then you discontinue it. So 4 milligram TDS for a week and then watch for the response. Continue for another week and start taper if there is a response. If no response, discontinue.
Second question by Dr. Vakas, again for Dr. Aisha. You mentioned that 400 milligram HCQ in preventing role in reducing the risk of congenital heart block. Will it not increase the maternal risk of active retinopathy and related to HCQ? And how to proceed with it?
So excellent question, and I emphasize 400 milligram, hoping that somebody will ask this. So the risk of retinopathy is related to the cumulative dose of hydroxychloroquine that you use, and the risk goes up with after 6 to 8 years of full dose use of hydroxychloroquine. What we are recommending is a time-limited, high-dose hydroxychloroquine, not weight-based. Once she has delivered, go back to your weight-based dosing. Yeah? It is only during the pregnancy. The data is for 400 milligram. And again, there's some literature around it. It's an area under the curve. Why 400 milligram? Because it's just that the literature supports that dose. And the risk of retinal toxicity, I think we should not worry about it because it's only a time-limited use.
Thank you. I would request Professor Noman Tariq. Great, welcome. He has been our renal buddy for several years. Welcome, sir.
A big round of applause for Dr. Noman Tariq. So he has been like co-managing patients of lupus nephritis, and I have learned a lot from you, sir. Thank you, sir. आप भी मेरे उस्तादों में से एक शामिल हैं, and thank you for being here this morning.
Right, and again question by Dr. Asif to Dr. Aisha. If a patient had contraindication to HCQ use, other option to prevent heart block in Rho positive and LA positive mother?
So hydroxychloroquine has shown risk reduction. I mean, it's not like an absolute prevention. Not to my knowledge, there is an alternative. People have used plaques. There's some literature of using plasma exchange and IVIG for prophylaxis, but the IVIG control trial was negative. There was no benefit in reduction of risk. So again, there's no strong evidence for the use of IVIG. We just do the usual monitoring and treat early if there is any risk of or any signs of developing heart block.
I have a comment here. So as Michel Petrie says, HCQ is your buddy for the rest of your life, right? So usually the message for everybody here is that we have to monitor, and with monitoring the HCQ is safe. But most of the time when our patients go to other specialities and to physicians who, even to the best of them, because obviously there's no exposure to rheumatology, HCQ is the first medicine to be discontinued during pregnancy, or to the ophthalmologist who says, oh my God, you've been taking HCQ for like 2 years, this is toxic, you destroy your retina and get blind. So I think we should next time have our ophthalmologist from the periphery here also.
Yeah, so we are having an ophthalmology room board, and we are going to come up with this in tomorrow's meeting. So we are discussing that point as well, because we need to actually be on the same page as rheumatologists, as ophthalmology colleagues as well. But there are colleagues who have been co-managing these patients with us, and they send a clean chit after years and years. You don't need to come to see me before 5 years. This is your baseline. It is totally a safe medicine, and I'm thank God that this is what according to the American Ophthalmology Association guidelines, and now they are also following it. The things are changing. The landscape of rheumatology is changing, nephrology, and so is this kind of interactions which we are having interdisciplinary. They are actually going to improve outcomes. If chair allows me to have some questions from our esteemed nephrology colleagues. One confusion as a student which I always have, when I look at urinary albumin to creatinine ratios, which you people do all the time in your diabetic nephropathy patients, does that same thing applies because albumin is like 60 to 70% of the protein urea which we have. But for our guidelines, we generally have been following either 24 hours urinary proteins or historically, or then urinary protein to creatinine ratio, UPCR, for many years now. So what would be your take on it? So UACR versus UPCR. Dr. Noman, would you like to please comment on it?
Thank you very much. Thank you very much. Actually, you raise a very good point in terms of diagnosing or early detection of disease. So if you talk about the markers, we don't have too many of the urinary markers that we can use to detect any early disease other than having a proteinuria. Some cytokines and all those things, they are there, but they are not as frequently available and used. So if you are using albumin, so if it is more than 300 milligrams in 24 hours, then it will appear as +1 protein or even more than trace within the normal urine dipstick. But if it is less than 300 milligrams in 24 hours, it will not be detected in the normal urine dipstick. So you may miss it. But what we take is as a 0.5 milligram or 500 milligrams as a protein to creatinine ratio, which in 24 hours equals to like 500 milligrams 24 hours when we are talking about remission of lupus nephritis in general. When we are using PCR, we are using urine protein and creatinine. That is already beyond the 300 milligram limit of albumin. So in general, albumin to creatinine ratio is not as much advocated in lupus unless you want to detect an early disease. Otherwise, urine protein to creatinine ratio is fine, or a 24-hour urine protein.
Thank you so much. That's great.
Thank you so much for clarifying it. It means that at times when even you have a normal urine routine examination and you are still worrying about your patient who has low complements, high double standard DNA, and a phenotype which you really like the early onset, and you still can go for UACR in that patient or 24 hours albumin for that matter in order to detect it as early as we do in our diabetic nephropathy patients. Am I right?
So essentially, I think I would echo what he's saying. What I would say is to detect it, I would do albumin. But if I want to monitor the patient over time, because if it's lupus nephritis, I would do proteins because, that's fine.
Yes, that's what we... I have one question. We don't have volcosporin, and the cost of the medicines is like killing our lupus patients. So we have been using a lot of tacrolimus and we have been using a lot of cyclosporin before that was available. So one question is valcosporin, cyclosporin, or tacrolimus? We know that valcosporin is superior, but can we use cyclosporin and tacrolimus? That's a question from someone.
You want me to answer that? Or? Yeah. So I'll give it a shot to answer this at least. Yeah. So the benefit to my understanding with voclosporin is that it develops a trough level and then just maintains it. That's why you usually give it in an OD dose. Yeah. And you can't do that with tacrolimus, neither you can do with cyclosporin. So with voclosporin, the added benefit is that you usually don't need to measure trough levels and things like that. So that is where it came in, because when you take the cyclosporin and this tacrolimus, their levels goes up and down. And you might have seen that, once you go outside, there's lots of pharma companies as well. Everybody has its own formulations. So everybody maintains the trough level at a different R. And that definitely, we've seen this in our transplant population, that if, I'm not going to name a drug, that if I was giving this patient tacrolimus 1 milligram, and I just changed the brand because that was not available, the patient ended up in rejection. And the reason was that the trough level came out late. Eventually, the level was fine. But just because the Tmax came at 2 hours, it exposed the patient to that antigen and they ended up in rejection. And it was proven with our pool study in France. So that is where voclosporin comes in. In Pakistan, we don't have it. So I think my colleagues can also say, I don't use tacrolimus, I use cyclosporin, less diabetogenic. And we've got lots of problems with diabetes anyway. But, the guideline says tacrolimus, yes.
Yeah.
So I'm going to have a say here with this question. So tacrolimus, voclosporin, cyclosporin, all calcineurin inhibitors. We use them, but we use them as a third line. And in majority of the patients, we are wearing off their having an effect on the kidneys as a long term. And these studies, which has been conducted, are only till 3 years. And I'm going to say again, we don't know what the studies are after 3 years. So would the calcineurin inhibitors have an effect on the kidneys after the 3 years or not? We have seen that in our transplant population. Patients who are on calcineurin inhibitors, they do have TAC toxicities when we biopsy them, apart from when they have rejections or antibody or T cell rejections. So in a nutshell, my answer is yes, we do use tacrolimus. In some population, there's a big multi-centered study from Chinese, which used both a low-dose MMF and tacrolimus. My colleagues are now quite pro using small dose of MMF and tacrolimus from that Chinese study, and it has shown good promising results. With the trough levels, we used to keep it a little bit lower than the transplant population, between 4 to 7, and that's where we go from there.
We have the privilege of representation from APLAR region, and the burden of treating patients with rheumatic diseases is great, and we can't afford medicines. And I don't know about the other regions, but in Pakistan, the first priority of a young woman with lupus is, I am hurting, my joints are hurting, I don't want methotrexate, I can't, cytoxin, no way. And Cellcept, no way. I'm newly married, I have to have a baby. So give me a medicine that takes care of my joints, takes care of my kidneys, and I can get pregnant. And that's what they want. And I don't want any prednisone. And obviously we don't want to give them any prednisone because they have to have another baby. So this is our dilemma. Tom, what do you do?
I think I totally agree to such a feeling. All over the upper countries, the patient hesitate to use a glucocorticoid. And of course, the cyclophosphamide is a very dangerous drug for the bearing child, or it's a bone marrow suppression, neuropathy, etc. So nowadays, MMF is coming to replace the cyclophosphamide. And speaking about calcineurin inhibitor, we have a long experience for using the tacrolimus as well as cyclosporin. I am the first author to observe more than 10 years observation of tacrolimus use in lupus nephritis. That is called the TRUST study, just published in Journal of Rheumatology this year. So at that time, we enrolled 1,500 lupus nephritis patients treated with tacrolimus for the induction study. We observed much more than 10 years for individual patients. The retention rate is surprisingly 700 among 1,500, 14 years. So that is surprising. And no deterioration of GFR at the time. Yeah, so that is a very good drug. And also the voclosporin is a very potent drug. Initially, the concept is much more safer of voclosporin than tacrolimus or cyclosporin. However, the efficacy is very good. However, we should concern about the safety because of its potency of voclosporin. That is a concept.
Yes.
So there are lots of new things are coming.
Yeah.
Thank you.
But our friend has been cyclosporin, let me tell you, because we have an arthritis care foundation which provides them with tacrolimus, and women are so happy, they get pregnant, their joints are feeling good, and obviously we have to monitor them very closely, and I agree with the recommendation of having that trough level which is slightly lower. So is our friend for now because we can't afford anything else. Yes.
Can I add on something here? So it's very interesting to listen to you saying tacrolimus and joint pains. There are multiple studies recently done, and tacrolimus is, when patients complain of joint pains, it can be due to tacrolimus, and so we have then stepped down to cyclosporin for them in the transplant population. So we do use cyclosporin in our transplant population, but we haven't had an experience yet with cyclosporin. A few patients of my colleagues have been on cyclosporin.
I have seen, I don't know whether it's everybody else's observation, that we monitor uric acid levels, and surprisingly their uric acid levels are very high, and their joints are hurting when they are on either cyclosporin or on tacrolimus. So that's what my experience has been. So we make sure that, I wonder if it is due to that. I don't know why. So.
I think the uric acid being high is one of the criteria for diagnosing that particular condition. I can get back to you and tell you what exactly is that called, that terminology, where if we think that this patient has got bone pains because of tacrolimus-induced microvascular changes in the bone,
joints.
in the joints, yeah, tacrolimus, the uric acid level should be high if it is due to tacrolimus.
And also, I would like to raise some of the points. The dose is very important, and not only for tacrolimus, but also for MMF. And also the combination of MMF plus tacrolimus or MMF plus voclosporin, the dose is very important, particularly for the efficacy, for induction phase.
Yes. Lani has touched upon the dilemma of our region with tuberculosis and lupus. My God, that's a great challenge. Lani, we don't have money to do IGRA. We don't have money to do TB spot test. So what we end up doing is, let's do a chest X-ray, so because it's very expensive. So our foundation funds them also, but still it's very expensive. So sometimes we decide that we are going to do a chest X-ray and see, and if there's no contact in the family history, and they are not looking like the fever is due to TB, we just go with the chest X-ray with hoping that we are not missing out on. I don't know, what do you say about that? When the cost is a big issue with these tests.
Yeah. Thank you for the question.
One question from Professor Dr. Tajwas Saber, so she wants to ask.
Yes. Yeah, I just answer it quickly. Then, yeah, it's very difficult to decide if we cannot test for the IGRA, but I mentioned the IGRA is also difficult to determine this is TB or not. So we follow up the patient and to see if you already give all things for the disease activity, but still on fever or coughing, or maybe we should look for any other cause for the infectious disease. So yeah, it's important to rule out the tuberculosis.
I think one more issue here is that if you have a negative IGRA in this population where we have quite frequently exposed to tuberculosis patients, what to do? So should we give them then INH prophylaxis?
Yeah.
So there is a session, Dr. Nauman, on Rheum and ID board, and we are actually coming up with consensus on that. We have infectious disease specialists joining us. That's going to be scheduled tomorrow, and I would really like you all to be part of that board as well. I think now one quick question from the audience. Dr. Tajwar.
I'm Tajwar. I'm currently working back in the UK but provide a weekly clinic for Peshawar. I just wanted to ask, so when I write a prescription, a lot of you might come across this as a very Pakistan-based problem. So I write a prescription, I empower my patients, I give it in writing, I educate the patient. But when I give a prescription to my pregnant patient, the gynecologist stops all the medicines, including hydroxychloroquine. Do you have any intelligent solution? Because I mean, I have for years been fighting this, and I don't know how to reach, because the patient in Pakistan chooses where they go randomly.
Can I answer that? So if, we basically have the recommendations typed in hard copies, and we make a point of outlining, highlighting the drugs that are safe, explaining to them, not once but twice, and also to the family. That's very important. Either, the husband or somebody from their family, and also write a note to the gynecologist and say that, yeah, so you have to basically convince her and the family. If they understand it and you give them an out that, the doctor can speak to us, give them somehow or the other. So I think, mashallah, we've had very good compliance after that. We've had one or two anecdotal, situations where people have, but mostly they will be compliant.
And the important thing is, it might be a problem in smaller cities and towns, but in bigger cities, we do have gynecologists who are in collaboration with us. And initially, they were skeptical, but with time, they have learned that these drugs are safe, rather very important for the survival of the fetus.
One last question, because we are running out of time. Dr. Mahfouz.
I got two questions from Professor Laniyati. These are both from Dr. Faiza, who is the SR of Rheumatology. One question is, due to high risk of false negative IGRA test in active SLE patients, what tests are preferred for screening such patients? False negative IGRA in active SLE patients, what other tests you prefer?
I think she wants to bring attention to, because generally they are on high dose of steroids by the time we send, and they are already have been pulsed, and their T cells are low, and we need T cells, and the result comes back indeterminate, T spot or IGRA, because of the fact that their T cells have been depressed. So how to go about that?
It's difficult. Yeah. And what we do, as we know that IGRA test cannot determine patient has TB or not TB, but only can express that the previous exposed to TB. So that's we cannot use the IGRA test in a patient with active disease. So if we want to find out the patient has tuberculosis or not, so we do for the clinical examination for the patient all throughout.
You mean to say that clinical assessment of a patient will tell if the patient has TB or not? So IGRA is not really necessary in those cases. Okay. The other question she has is duration of ATT in patients who are who have tuberculous monoarthritis and active SLE. What should be the duration of anti-tuberculous treatment in patients who have tuberculous monoarthritis as well as active
This
SLE?
question can be answered with the ID session we have, so please come there also, so we'll get the answer there. Any more questions? We have finished almost all the cards, but we are running out of time, so it's been a great...
I would now request Haris and Kainat to take the podium and distribution of souvenirs. And
just a quick comment on EGFR. We have faced a lot of problem with the EGFR in Pakistan. You guys also, we have also as nephrologists. Our Khan lab started giving the EGFR initially more than 60, less than 60. It doesn't make any sense. And then they started giving us the EGFR. Then they started giving another EGFR based on their own data, which was very robust data. for a Pakistani population, which is actually less than what we calculate with the EGFR, with the EPI formula. You can just calculate with your app, with just putting in the creatinine and age and the gender of the patient, EGFR, EPI, which is the standard nowadays. As Dr. Fahim and Dr. Ahad mentioned, that the dosing was based on the Cockcroft-Gault formula. However, the latest medications, they can all be easily calculated based on the EPI EGFR formula. And the other formulas which are being used are probably not as much robust, so that if we use with our calculator, it's available, EPI or the labs which are giving them and they have written it, this is an EPI, then that is the one that you should take. So weight, yes, it is important because many of the times you have to calculate the body surface area corrected to that, and which you can't do that, without that. And so then it becomes very difficult, how to do. So as a general rule, whatever the lab is giving you as a formula is mostly EPI. It may be little less than actual what it is. So what I now do is that whatever the EPI formula comes in through the lab, I just add a 4 or 5 ml to that, and that's usually correct.
Thank you so much. We have to finish. I really am grateful to the panelists, to the audience. We lack of time. Dr. Ranja and Dr. Ibrar Hussain, please, we'll meet at a cup of coffee and then we'll discuss this because we are running short of time. So can you finish this, please? Thank you so much.
All technical, which has been very extensively discussed, and the sharing is appreciable. But one thing is that in Pakistan, as a community specialist, say the decision about not made by the patient himself. It is affected by the community, and people guide where to go, where not to go. Similarly, the most important, maybe even the ladies sitting in this hall may not agree with it, but after having put in 45 years experience in the field, I still hold my opinion that the decision about all the events of gynecology, pregnancy, is not made by the pregnant lady herself, but it is affected by the mother-in-law mostly. And this is not the decision to be made by the patient herself that she will come back to the rheumatologist. It is the decision of somebody else. Therefore, we have to go for the community participation. We have to go for the public awareness. And second part of it is, that this is called professional honesty. I don't know about other countries, but one thing is very important, that this is not specific to rheumatology only, that a patient once referred to any other ology will come back. It is common to all. So the problem I have identified is that the physicians they display their all degrees, that FRCR, FCPS in their clinic, but they never display the oath they have taken as a doctor. They never display in their, and that's why they almost have forgotten. So once more, I will request you, madam, that PSR should take a lead, that the doctors should remember their oath which they have taken while entry into this profession.
Bilkul sahi hai, do not harm. That should be our oath, and educate the husbands. Thank you, PSR. Thank you, Eplar. Thank you, everyone. It was great discussion.
Thank you so much to our speakers and chairs for a thoughtful exchange. I would request the worthy chairs, Professor Nigat Mir Ahmed, Dr. Mahfouz Alam, Professor Samia Malik, and Dr. Bilal Azim Bhatt to present a token of appreciation to our speakers. So that, first of all, we have Dr. Aisha Lateef. Our worthy chairs, Professor Nigat Mir Ahmed, Dr. Mahfouz Alam, Professor Samia Malik, and Dr. Bilal Azim Bhatt will present a token of appreciation to Dr. Aisha Lateef. Next up, we have Professor Laniyati Hamijoyo. Dr. Behram Tariq. And lastly, Dr. Tahira Parveen. Now we would like to request Professor Nigat Mir Ahmed, Professor Sumaira Farman Raja, and Professor Ahmed Said to present a token of appreciation to the chairs of the session. So first of all, we have Dr. Mahfouz Alam, Professor Samia Malik, Dr. Bilal Azim Bhatt, and lastly, Professor Nigat Mir Ahmed. Lastly, Professor Nigat Mir Ahmed. Now we would like to present a token of appreciation to the distinguished expert panelist. First of all, we have Professor Stomu Takayuchi, Professor Stomu Takayuchi. Everyone kindly please maintain the decorum of the hall. Next up, we have Professor Noman Tarif. Dr. Muhammad Ahad Qayyum. Dr. Fahim Usman Sulehri. And lastly, Professor Sumaira Farman Raja. Thank you so much, everyone, for joining us on the stage.
May I request all the delegates to be back in their seats after grabbing a cup of tea, because we would be starting next session in 5 minutes. So.